All right, you guys. So we are jumping into a miniature unit here. This is a neuromuscular unit. It's going to cover a number of different diseases and disorders, but we've already kind of talked about Guillain-Barré, and now we're going to move into another neuromuscular disorder called Myasthenia Gravis. And we're going to talk about, again, the etiology, the pathophysiology, clinical manifestations, diagnostics and treatment for all of those, and really who's at risk when it comes to myasthenia gravis. So let's just jump right into this and see what we can get into. So when we start out with myasthenia gravis, this is the most common chronic neuromuscular disorder. So what it does is it interferes with the transmission of acetylcholine to the axonal terminal and the receptor site. So imagine if you were trying to send a text message to somebody and you are in like a no service zone, right? When you send that message, if you get service, it'll go through. But if you don't get service, that text message will never go through. Well, this is kind of what it's like to have myasthenia gravis. You are sending messages, the messages are being sent, but the signal is not strong enough to receive that message. So you end up having kind of this loop of message being sent, message being sent, message being sent, but it never actually makes it to the recipient. So it never makes it to the axon terminal or the receptor site. When we look at acetylcholine, this is really responsible for controlling voluntary muscle movements and involuntary muscle movements. So we get acetylcholine that is responsible for controlling voluntary muscle movements. When we look at the hallmark sign, anytime that you see hallmark sign or the gold standard, go ahead and put a circle around it, put a star, underline this. It's a fluctuation in skeletal muscle weakness. So there's going to be weeks, months of chronic fatigue or true muscle fatigue, and then it will improve after a period of rest. So when we have this, we have two different types. You have the ocular and you have the generalized. The generalized would be more like the drop head syndrome. So if you had somebody whose head was flat down like this, what do you think you would see in terms of obstruction to the airway? Well, if we think about CPR, we put those patients in a sniffing position. We open up the airway by getting their head up. Well, when we have that flexion, it'll actually close the airway and create this opposition to flow or increased airway resistance. With generalized, you get involvement from muscles of the mouth, those that are responsible for speech or even swallowing. You can have upper body limbs that are involved, the respiratory muscles whenever it gets really bad, and facial muscle involves. Really, the patient will appear kind of expressionless. They won't have any expression at all. So when we look at this, this is kind of the signals being sent, but there's no place for those signals to land. And one of the things that we might see when it comes to myasthenia gravis is what's called fasciculations. And fasciculations are these like wave-like movements of the skeletal muscles that are involuntary. And I've got a little video here that I'm going to show. Look at these muscles. These muscles are moving without direction, right? The patient here is not telling them to move their tongue in that fashion, in that manner. So let's look at it again. Let's see if we can run this back. So if we look at it, you've got this involuntary movement of the tongue that is what we call fasciculations. So fasciculations would be those involuntary movements of skeletal muscles that happen. We see these oftentimes with patients that are about to be intubated. When they get sedation and paralytic, you will see fasciculations in the neck or the upper chest, even the arms, you can see these wave-like movements or these involuntary movements, and that helps us recognize that that patient is ready for being intubated if we're trying to sedate and paralyze them. So fasciculation is a new word and a new term that is associated with myasthenia gravis. So when we look at the general type of myasthenia gravis, you're going to see that there's going to be general weakness that's associated with specific muscle groups, or it can be an overall weakness. Now, if you get somebody that has, or you have a STEM or a question that talks about respiratory care practitioner responds to a call in the emergency department for patients whose chief complaint is generalized weakness or fatigue, right? So we can identify that generalized weakness. It could be associated with Guillain-Barré. It could be associated with myasthenia gravis. It could even be associated with sleep disorders, right? And those patients could present with the same symptom. We just need to start to get more information so that we can identify truly what's going on with our patient. So what would happen if we have this myasthenic crisis or the myasthenia gravis that has navigated its way from, it's a descending disorder. It's navigated from the kind of the way I like to remember it is mind to ground. So it's a descending disorder that goes from the head down to the toes. So this is a descending disorder, and when you start to get diaphragmatic involvement, this is what's called myasthenic crisis. Myasthenic crisis. So you have patients that are having fatigue in their diaphragm or even weakness and sometimes even paralysis of their diaphragm that's going to lead to ventilatory failure. Well, if your diaphragm's involved and it's weak, are you going to be able to cough effectively? Are you going to be able to mobilize secretions? Could those secretions create an obstruction? That obstruction creates more consolidation and you end up with alveolar consolidation. And if you're not able to open up or move volume the way that you're expecting to, you could even end up with alveolar collapse. What did we say that alveolar consolidation or complete alveolar consolidation and complete alveolar collapse are? We called it a specific term. Yeah, that would be a true shunt or an absolute shunt. And this is where we have a big VQ mismatch. So just remember, you're going to see anatomical alterations or changes in the pathophysiology very, very similar to Guillain-Barré. When we look at the cause of myasthenia gravis, it appears to be related to the acetylcholine receptor antibodies. And these are IgG antibodies that end up blocking the nerve impulses and the transmission to the neuromuscular junctions. So there's something that is preventing or blocking that signal from getting to the receptor site and allowing the skeletal muscle to receive the signal to perform whatever task that is being signaled, right? Patients who have these detectable antibodies of the acetylcholine receptors, or what's called the muscle-specific receptor tyrosine kinase, or MuSK for short, are said to have what's called seropositive myasthenia gravis. So when we look at these antibodies or these immunoglobulin antibodies, they really disrupt the transmission of acetylcholine. So when that happens, they are blocking acetylcholine from the receptor site of the muscular cells. So you're blocking the signal for the muscular cell to do what it's supposed to do. And what this does is it accelerates any sort of breakdown of the acetylcholine, and it's not going to function. Well, when you break down that acetylcholine, it will actually destroy those receptor sites. It's part of a destruction and a deterioration of those receptive signals. And when we look at this, it typically only about 35,000 to 60,000 cases in the United States. When we look at this, typically males that are from 40 to 70 years old, they're provoked to go into or have myasthenia gravis secondary to some sort of emotional upset, some physical stress. They're exposed to extreme temperatures, becoming febrile from an illness. And with women, we can see this in pregnancies at times. And typically, that age range with women is a lot younger, from 15 years to 35 years of age, where we'll see myasthenia gravis in women. Now, what's the screening look like? What are we kind of evaluating when it comes to taking care of these patients? What are they going to present like, and what do I need to do when they present this way? Well, just like with most of our conditions, you want to look at their clinical presentation and get a good health history. When we get those health histories, we're able to understand and get more information and some insight as to what we need to do further. So the other things that we're going to start looking at is some bedside tests. We'll talk about those, some immunologic studies, the electrodiagnostic studies. We kind of touched on these a little bit with Guillain-Barré, and then we're looking at anything that, or we're going to evaluate any known associated conditions. So the thymus gland is highly associated when there's impairments or disorder in the thymus gland. There's a strong correlation with myasthenia gravis. So what is your patient going to present like? Well, the hallmark sign is chronic muscle fatigue. So this is going to be the most common and the hallmark sign that we see with myasthenia gravis. So the patient's going to have progressive muscle weakness with activity, but it will improve with rest. So other telltale signs that we see with myasthenia gravis is going to be this facial muscle weakness, or ptosis, or diplopia, and then this last one here. So when we look at these three things down here, ptosis is the drooping of one eye or even both eyes. So you get this drooping of the eyes. Well, what is facial drooping also associated with? It's one that we haven't talked about. It's one that we will talk about, but it's a common disorder that we see or we associate with another condition. So where do we see ptosis in another neuromuscular disorder? Diplopia, and then this other one, diplopia, is double vision. This other one is paralysis or weakness of one or more muscles that control the eyes. So those are some of the common clinical presentations that we will see. Patients are going to continue to present, and they're going to have a difficulty in breathing, maybe even speaking or swallowing. They're going to have an unstable gait, meaning that they're not going to be able to walk in a normal pace and gait. You could have a loss of balance. You're going to have weakness in the arms and the hands, fingers, legs, and even neck. If you get that weakness in the neck, you're going to see that drop head syndrome. Muscles that control the eyelids or the eyes, face, and even the throat. It can descend down to the chest wall and even the diaphragm. So if it gets to that point, it's going to impair the patient's ability to take a big deep breath in and even cough. Well, one of the big deep breaths in that we take that's just that's part of the autonomic system is 6 times out of an hour. About 6 times out of an hour, you will yawn, you will sigh, you will take some sort of deep breath to reset your diaphragm. So because I said that you're going to yawn, I bet a few of you actually yawned whenever I'm saying that. But other things that we're going to see, early stages of myasthenia gravis are typically hard to detect. These patients are experiencing very subtle and intermittent signs and symptoms, but sometimes these signs and symptoms can come on sudden and rapid. So when we look at this, patients can have normal health for weeks or even months at a time, and then they experience that fatigue, and then they have that fatigue for days or even weeks and sometimes even months. So, like I said, it can show signs of weakness only late in the day or the evening, which is typically common. Like, who isn't tired and perhaps even a little bit weaker later in the evening, later in the day? And you can have the development of sudden and transient generalized weakness that gets to diaphragmatic involvement, and now we're going to have a lot of concerns and a lot of issues when it comes to being able to take those deep breaths and cough.